Welcome to AETCM, the emergency medicine channel.
Yeah.
Presenting the case of 65-year-old male patient who presented with complaints of swelling and pain around the nail folds of right middle finger. On 10-second assessment, airway was patent, no secretion, no gurgling.
Straight away go to the local examination.
Okay. On local examination, around the right middle finger, there was mild tenderness and swelling around the nail folds. There was an erythema present and there was an abscess collection around the nail fold. Coming to the sample history, 65-year-old patient presented, known case of hypothyroidism, presented to ER with complaints of swelling and mild pain around the nail folds of right middle finger since 3 days. It was gradual in onset and progressive in nature. The swelling had initially started around the medial aspect and then progressed to the base and the lateral side of the nail. There is no history of trauma, no history of nail biting, no history of ingrown nails, and no history of fever. Adjunct to the primary survey, we had done a CBC CRP, and in CBC the total count was 8,400 with a CRP of 2.8.
Why you wanted a CBC CRP for a nail bed infection? You don't ask for any infection. That one prick you can do somewhere else and patient can be discharged. So unwantedly don't ask for this infection unless and until he is immunocompromised, he is on any chemotherapeutic agents, or you feel that he is in sepsis with any of other features of SIRS, like he's having high grade temperature, he's having hypotension, low count, then only you need to actually look in for the TC and all. If anyone is there, you can do what? Early warning score, or you can do what is the bedside evaluation that you can do quickly for any patient coming with sepsis. Q-SOFA you can do and see whether it is required or not. Don't do all those investigations for all the patients that is requiring. Okay, so basically you have a 64-year-old lady or male patient who was coming with a nail swelling and pain over the medial aspect to start off with, and later on it increased into the lateral aspect also. What we are dealing with, probably we are dealing with an Paronychia. So Paronychia is one of the most common presentation of nail emergencies when you consider. So that will be one of the most important questions. You have said regarding few precipitating factors like trauma. So one of the most common thing. And what are the other things? If it was like, what are the other reasons that you can have Paronychia?
Patient can come with habits like nail biting, thumb sucking, etc. Then patient can have ingrown nails, which causes Paronychia. Most commonly in toenails it will be there. Then patient can have some drug history, taking antiretroviral drugs or any chemotherapeutic agents or any epidermal growth factor receptor blockers.
So that's all very rare, but most commonly trauma. That is a mild trauma, or maybe a small, maybe minor trauma. Maybe they will not be remembering that also. Most common one is nail biting, and another one is that who are very aggressively doing this manicure and all those things they can develop. That's a male patient, unlikely, and maybe they are regularly having some exposure to the chemicals when they are washing the utensil at home. When they are chemical exposure, all those things, they are prone to develop these things. So that is a one thing. And one differentiation that we need to consider, whether it is really a Paronychia or there is something like chronic nail disorders. Maybe it can be an underlying fungal infections also is a possibility. On onychomycosis also there can be other differential diagnosis you need to consider. So you need to clearly say that what is the next complication of Paronychia?
Phelon.
It can go on to a phelon. So whether it is just a Paronychia, whether it has gone to a phelon. Basically when you look into the initial aspects, the treatment wise, there is slight difference. When it is a phelon, definitely you need to do a drainage. But when it is a Paronychia, maybe the collection, the fluid accumulation has not happened. Early you can just treat with what? What are the initial treatments? So we'll just classify Paronychia to the initial phase. The patient has just come in with mild swelling. Not this patient, I'm just asking mild swelling. There is some erythema and some tenderness is there, but there is no fluid collection. So how will you treat that patient?
Patient can be given some anti-inflammatory drugs and then can be given with topical antibiotics.
Okay, so topical antibiotics, example?
Mupirocin ointment.
Ointment can be given. So the most important thing is in gram positive. Being on the skin, it's gram positive, and you can give some warm just like what we'll do for your chalazion and all. You can ask them to do some warm hot compression so that the Paronychia will subside. So that will be enough. You doesn't need to drain or do anything of those sorts. But whenever it is increasing in size, there is a clear fluid collection, definitely you need to let that out. So what are the options for letting that out?
Incision and drainage can be done. Using a surgical blade, 11 size blade, we can put an incision on the point of maximum fluctuance throughout the abscess, and then the pus can be drained out.
Okay, so at that time, the most important thing, you have to give a digital nerve block.
Nerve block.
Because it is going to be excruciating pain for the patient. So do a digital nerve block like what we discussed for the last terfination. Similarly, you can just put a digital nerve block and do the procedure. Both lateral aspects and medial and lateral aspects, you infiltrate with your lignocaine without adrenaline, and you drain that swelling. So that is one thing. And another thing, you can use an 18 gauge needle. That is much more easier, and keep the bevel upside. It should not be downside. The bevel should be pointing upward, and you just prick to the, maybe in the nail bed, to the lateral side, you just prick it and the pus will come out. That itself will relieve the pain, and maybe a small dressing you can give, and after 3 to 4 days they can open up and see, and if any further soakage or anything is there, you can give further dressing. So routinely it's a simple procedure which we can do in the ED bedside, which doesn't need any major surgical intervention. Even if you don't have a scalpel blade, use a large bore needle. That's only suggestion. Use at least an 18 gauge needle, and you just go inside and you let that out. So that is a treatment for your paronychia. And when you're doing incision drainage, there are two methods. One, as you said, you're just going and where there is maximum drainage, or else you can just go laterally to the nail bed and you can just dissect, put an incision so that all the pus can be easily removed. The most important thing, whether there is an underlying nail bed or a nail plate, there is another associated with the trauma, then you need to have further evaluation, maybe sometimes an X-ray if there is a trauma related, but otherwise you don't need anything else. So that is your paronychia. Then you discharge them off with antibiotics. So amoxicillin, clavulanic acid, or amoxicillin, plain amoxicillin will also be enough. So when you have immunocompromised patient, you think in terms of a gram-negative infection, and very rarely you can have herpetic vitiligo on that area. So that is one of the differential diagnoses that you need to differentiate, but it will be a small ulcerative sort of a skin lesion that you will be able to see in the skin. That time you need to give acyclovir. Systemic acyclovir is not required. Maybe a local acyclovir cream itself will be sufficient enough. And other one is diabetic, chronic diabetes. They can have this fungal infections. So if it is a chronic paronychia, you have to treat them. So it's a treatment of chronic paronychia is a little bit tricky. So one more thing that you need to do is you can have this paronychia on your foot also. Not all the, but if it's a diabetic and there is a paronychia over the foot, mostly it will be a fungal infection. So we have to look for the web space also. So the web space inspection is very common. So what you need to do, maybe you need to give some systemic antifungals like fluconazole 150 OD weekly for the next 4 to 6 weeks. Weekly, it's not daily regimen. And other thing that you need to have is, one is candid lotions are available. There are nail lacquers, just like our nail polish. There are preparation available of candid, so we can apply it over that area so that it will stay. When you are applying cream or lotions, it will stay for some time only. So when you are applying this nail lacquer and all, it will stay for some time. So that is one thing, that option you need to remember. So it's an acute paronychia, chronic paronychia. Acute paronychia, only inflammation you have. Acute paronychia with abscess formation, then the paronychia can become like phelon. So when it's a phelon, definitely you need drainage. So how will you manage phelon?
Incision and drainage, and then we give antibiotics for the 7 days, and then following the 7th day we just open and see whether the wound is healing or not.
So that is your phelon. So pretty simple and straightforward. So when the patient comes to the ED, our concern is to relieve their pain. So oral analgesics will be more than enough. Rather than going for an IV injections and all, you just put that cannula or put that 18 gauge over the paronychia itself and you drain it off. And you have to tell them what are the precautions that you need to take in, whether they can have recurrent paronychia. This patient can come back with recurrent paronychia. When you are not generous enough to put an incision and drainage, when you are not put a proper 18 gauge needle, we are using a smaller gauge needle. The initially maybe a 0.25 or 0.5 ml of pus that is coming out will relieve the pain. But you need to be generous enough to get a good prick or a good incision and drainage. Otherwise, it will not be clear. And I will prefer why the needle part is because we are not destructing much of the needle plate, nail plate and all. The other one, if you are going a little bit deeper and all, there is a chance that there can be an excruciating bleeding. This usually an 18 gauge needle puncture is not very difficult one to do, and anyone can do. Even some patients, if I have got one, I will do it at home only, because that's if we can tolerate the pain of that procedure. It's that simple procedure. Anything else that you want to add on? can just, what all the risk factors?
Mainly the risk factors are the habits like nail biting, thumb sucking, and then ingrown nails are the main cause. Then minor traumas like during the gardening or with the thorn prick, it can cause.
Tetanus prophylaxis is one thing. If there is a traumatic, you feel it's like gardening and all, if you're having this, so think about tetanus prophylaxis. And another common thing that I had seen, not very commonly, there can be small fibers that would have, like if they are in the garden and all, the thorn would have been stucking in, but you need to clearly examine that area and thorn need to be taken off, or there may be narrow fibers out of a thing that need to be taken off. Otherwise, what will happen? The patient will have significant pain. Once you remove that itself, the patient pain will be subsided. Tetanus prophylaxis you can keep in your mind. If you feel the patient require a tetanus prophylaxis and is not taken a tetanus prophylaxis, yes, he needs. And antibiotics and amoxicillin clavulanic acid would be sufficient enough. Clindamycin, when you suspect an MRSA, but unlikely to have an MRSA, usually we don't see MRSA from the community, but you suspect MRSA, then you can give clindamycin, or you're thinking in terms of an anaerobic infection. So anaerobic infection, yes, diabetic, some blackish discoloration and all you are seeing, and the patient may be in early sepsis, you might be thinking of that term. Otherwise, usually you don't need MRSA coverage. And gram-negative Paronychia is very, very rare, and you can see it in immunocompromised. And one more thing, that is chronic Paronychia, that is fungal infection that you need to consider, and the differential diagnosis, what you need to have. Okay, fine. Thank you.